All right, let's get started. Good afternoon, everyone, or good morning, depending on where you're joining us from today. Thank you so much for joining us. We have a really exciting conversation for you all today, thanks to our incredible panelists who are community partners participating in Medicaid health-related social needs or HRSN reimbursement waivers across the country. Before I introduce everyone else, I'll start with myself. So my name is Emily Anders, and I'm the Director of Payment Strategy at Unite Us, which means through my role, I really get the opportunity to work with, learn from, and strategize with stakeholders across the country as they are in various phases of their HRSN reimbursement programs, whether that's ideation, planning, implementation, through to evaluation. And I am thrilled to be able to bring this important discussion to a more public webinar format because I know there's so much knowledge sharing, best practices, and lessons learned that stakeholders who are in their own respective phases of these programs are really asking of one another. So with that, I will pass it over to my co-moderator, Lauren Pinacchio, who joins us from Intrepid Ascent, to introduce herself. And I am thrilled to have Lauren co-moderating this conversation with me since she brings years of experience both in breadth and depth to the discussion today. So Lauren will also run through some webinar housekeeping items, and then we'll introduce our panelists and dive in. So Lauren, can you introduce yourself?
Awesome. Yeah, Emily. Hi, everyone. Good morning, good afternoon. Hello. Lauren Pinacchio, she, her, a pronoun series. I am the Director of Community Health Transformation at Intrepid Ascent. What that means is here at Intrepid, we recognize that the work of community health requires sectors to work together. I like to say the many systems that impact health have to work together in new and exciting ways, we would like to transform the way health is being delivered. And in my role, I get to have lots of conversations with folks across the country to think about the ways we can galvanize opportunities to invest in smart programs that help us design and implement programs across sectors, think about technology infrastructure necessary to breathe life into that, and really capitalize on and design ourselves the policies that are going to advance the equitable partnerships across those sectors, which is my way of saying I could spend all day in this room with you all. So I'm going to try to not, and I'm going to try to be respectful. Also, you heard it. I am from New York. Shout out Brooklyn. Hello from the Bay Area, though, where I call home. With that, I'll give a quick high-level overview of the webinar to Emily's point. So we have a really exciting conversation today where we have folks from across the country who are actively in leading community-based organizations who have really taken the step to galvanize and use the opportunity to think about the equitable partnership between healthcare and social services and community-based organizations, to think about how to provide holistic care to folks and really using Medicaid waivers and innovation waivers as a means by which to invest and make those programs happen. So we're really excited. We've got a few questions to help get the conversation started. I'm sure you've already noticed, I already see one question. There is a question and answer box. As we're discussing, please parking lot your questions. Put them in that question and answer box. Our team on the back end is moderating that. You will note there's no chat, so use the question and answer box appropriately. And then we will save at least 10 minutes at the end. I like to be reasonably aggressive, so maybe more than that if we can get to it. At least 10 minutes through some of those questions, which we're really excited to hear from. And with that, I'll pass it back to you, Emily, to introduce our panelist.
Thank you so much, Lauren. And like Lauren mentioned, and we were joking earlier, we could spend hours on each of the topics that we're going to just try to touch on today. So let's get into it. We're going to start with kind of a loaded introductory question for all of our panelists. So as we go through introductions, could you all introduce yourself, your organization, as well as provide kind of a high-level overview of the waiver structure within your state, recognizing that all of these states, as they're beginning to plan and implement these waivers, they all kind of take a different flavor. So we'll start with you, Lori, then go over to Rochelle and Brandon.
Sure. Thank you so much, Emily and Lauren, and to Rochelle and Brandon. Excited to have this conversation today. I'm Lori Andrade, Executive Vice President at the Health and Welfare Council of Long Island, leading the Healy Social Care Network as part of New York's 1115 waiver. Health and Welfare Council of Long Island has been around since 1947. We're the umbrella organization of all health and human service agencies on Long Island. We have a network of about 200 health and human service agencies. Part of what we do is we build coalitions to address issues, and we've been leading Healy as a coalition since 2017 for the original New York State waiver, really preparing ourselves for this moment in time where, because New York State's waiver is really focused on the provision of screening and the provision of care through social care networks, or a hub model, by which there's a lead entity, Health and Welfare Council of Long Island being the lead entity of Healy, the social care network, which is a network of about 125, 130 organizations that will be together screening Medicaid members for health-related social needs, navigating them, utilizing Unite Us as our technology platform through referrals to either traditional social care services, or if eligible for enhanced services. So that's really the model by which we're working, introducing new enhanced services to Long Islanders, including enhanced nutrition and enhanced housing services. That's the model by which we're working, and the way in which Healy is leading on it.
Thanks so much, Lori. And Rochelle?
Yes. Hello, everyone. My name is Rochelle Simon. I am the Executive Director of the United Way of Pettis County. We are located in Sedalia, Missouri, which is central Missouri. I got involved originally with the waiver because in the state of Missouri, we had the transformation of rural community health called the Torch Grant that became available for our regional rural spaces to get access to some of the Medicaid dollars and to figure out how to best serve those populations. And so our local regional hospital, Bothell Regional Hospital, started this a couple years ago when this became an opportunity to apply to be a Torch pilot hub program. We stepped on to be supportive, and I've gotten involved in the leadership council and gotten intimately involved with our B3 reimbursement waivers. So we are now, in addition to working with other nonprofits in the area to get those social services connected with these dollars as well, to get the reimbursements to help the folks in our community on Medicaid. And so for us specifically, what that looks like is environmental modifications to homes using that B3 waiver. So it's a little bit about me, and I look forward to the conversation.
Thanks, Rochelle. And over to you, Brandon.
All right. Thanks, Emily. Brandon Wilson. I am the Chief Operating Officer for the Asheville Buncombe Community Christian Ministry, a faith-based nonprofit organization based here in North Carolina. We got a lot of exciting things going on in North Carolina. Our waiver originally was a part of a $650 million investment that came through CMS through our former Secretary of Health, Dr. Mandy Cohen. Well, we were really looking to address 4 specific domains of reimbursements through our Healthy Opportunities pilot. Those domains regarded the social drivers around transportation, housing, food insecurity, and interpersonal violence and toxic stress. And so our Medicaid, our reimbursement structures are based around those 4 domains across 29 different payment models that live within each one of those. In the same time period, and I say a 3-year time period, we were also undergoing Medicaid transformation to a managed care program where we are now leveraging prepaid health plans, both with the standard plans, physical health, and also with our behavioral health and IDD plans with our local management entities and MCOs. And then also in the same breath, we expanded Medicaid in North Carolina last December. And so we've had a lot going on here in North Carolina, but really glad to be here with all you leaders and hopefully take away and copy and paste off of Lauren, you, Rachel, and Lori, and the work that you guys are doing as well.
Thanks so much, Brandon. And for our audience, you just heard it, but also just want to reiterate that these 3 panelists are also, and their states that they're representing are really in different phases of their Medicaid transformation waivers. So you just heard from Brandon, who HOPS launched, what, Brandon, almost 3 years ago at this point. Rochelle, who I know you all just began to participate in the reimbursement for the B3 services a couple months ago. And Lori, we are marching quickly to a January 1st launch date for New York. So really different phases and perspectives for you all to be able to offer, and just so thrilled that you all are here today. So thank you. Quickly to piggyback on those introductions, I know there's obviously tons of different components that go into these waivers. Can you all give a quick overview of how you are leveraging technology specifically to be able to meet some of those waiver requirements? So we'll go in reverse order. So Brandon, starting with you, and then over to Rochelle and Lori.
Yeah, thanks, Emily. Yeah, so I think in North Carolina, we were really fortunate that we had adopted as a state the technology platform with Unite Us to help just connect, improve the efficiency and delivery, and track those services across all social determinants of health, not just the 4 that we're getting reimbursed for currently. So we started this actually in the veteran subset back in 2014 in North Carolina. And so when we started that, it was creating a shared technology to send and receive referrals tracking all social drivers of health in the veterans subset of the population, which we took lesson learned and we grew proportionally, and then launched that in 2018 with what we call NC Care 360. So that technology was the backbone and the foundation of how we knew we were going to then get paid through Medicaid reimbursement, through our 1115 waiver, partly because we knew it was coming. But I think it's important to understand that our community was used to using that technology already. So when Unite Us built the functionality of being able to be reimbursed on that same platform, it really was an easy shift and easy way to use what we had been using to track referrals, to send referrals, to use data to inform strategies and resource allocation and funding allocation across the continuum to be able to do some of those services. And so I think that was what helped us really accelerate our ability early on, as we had already adopted a shared technology platform that we migrated very seamlessly into our payment structure.
Thanks, Brandon. And then Rochelle.
Yes, so we in receiving the Torch grant, which again it came through our state, our local area, one of the things that came along with that before the reimbursement waiver was capacity building funds. And those capacity building funds allowed us to start to utilize Unite Us, which I have to say has been invaluable in our community. So we, just a little bit, I didn't share before about my community. So I am a single person United Way. We are a small rural community. The United Way of Pettis County serves 48,000 folks. But we have robust nonprofits. And I think the communication that it has allowed between our social service agencies, our health providers, all of those different things has been, like I said, very vital. So about a year ago, is before reimbursement waivers, payment structure, any of that was set up, we started utilizing and encouraging folks to sign up for Unite Us and communicate to give and receive referrals for programs in our area. And that got folks on board, got people excited about the communication and the efficiency and the ways in which we can work together to serve folks' needs. And so then it was a matter of, okay, once we've got that set up, people understand how technology and Unite Us specifically is really helpful, then added a little bit of the payment structure and the reimbursements, specifically for the B3 waivers. But I think that one of the things that it's allowed us to do the technology is to not only communicate with one another, but streamline and make more efficient the timing. Things were moving slower before, and now they're moving a little bit quicker. And that helps people get their needs met quicker. So we're that's been grateful for that.
Thanks, Rochelle. And I'm really happy to hear that. Lori, to round this one out.
Sure. So as I had mentioned, Healy began in 2017 out of the original New York State waiver, 1115 waiver, and we received a CBO planning grant at that time to be able to plan and how to engage with healthcare in integrating healthcare and social care together. And when we brought folks together to form Healy, very quickly, we want to make sure that we have the correct infrastructure in place by which to do this work and really understand how to build out strong social care infrastructure so that we can have good integration with healthcare. And so we had actually RFP'd out and selected Unite Us to be our platform at that time, and began the process of onboarding folks, CBOs, to be a part of Unite Us. and really partnered hand in hand. And I think that was the big piece of why Unite Us we ended up choosing Unite Us, because it's a tool by which to make those interconnectees, those referrals, right? Where we screen, we refer, we connect people to services, but really they know that services get provided by humans in community, but they partner with us in doing that work. They've been at the table with us since 2017, monthly, coming with us and bringing people on board, helping us train them, CBOs on board, and training them and being a part of this and sending and receiving referrals. So as we fast forward to this waiver, we were already really in place to do that and have that infrastructure, that the technology infrastructure. And now being able to, it really is required for HILI members to be able to screen and refer and be able to do those claims in Unite Us is like that's when we sign contracts with us to do that work, it has to be in Unite Us. So, and it's really been a great partnership over all of these years, and a growing experience certainly in the last 6 months as we've received the award for the waiver to be not just a CBO planning grant, but to actually receive the infrastructure dollars to be able to do this work. So, and then as Emily said, heading towards January 1st in terms of, I like to call it rollout of all of our services, and that we'll be providing.
Thank you so much, Lori. And I think that all of your kind of responses begin to get into our first topic. So I'll pass it over to Lauren, beginning to get into like that change management capacity building component.
Yeah, when we did our panel prep, we were all laughing about how like this isn't a moment thing, right? Like this is a movement. This is years of grinding it out and working together to be ready for this. So to build on the conversation we were just having and hopefully expand beyond the dimension of technology, which is important, but as Lori mentioned, just one of the things that makes service delivery happen. I'm curious if folks can offer reflections on what work did you all need to do to determine to say, yes, I want to be involved in my state's waiver in this leading capacity? And maybe I'll kick it off to you, Brandon, to kick us off in that conversation.
Yeah, thanks, Lauren. Well, fortunately, when the state decided to go in this direction, we were, as an organization that was already using Unite Us and already at the stage of growth. Like we were 4 years into using technology for service delivery. I think for us, it was sort of a no-brainer to say, oh, so you're saying that there's a possibility that we may get paid for services that my organization has been doing for 50 years for free. And so we were at the table early on to share what those best practices were, what we had learned 5 years prior to Care 360 even launching, to 7 years before our payments even launched. And so it was sort of a no-brainer for us. I think that the leg up that we had is that we knew the technology, what the technology was capable of, and the customization and the assessments and the Tableau dashboards, the Unite Us insights that was available at our fingertips. I think organizationally, what we had to do separate of that was make sure that we had a strong accounting and finance team, because we had never billed for invoice Medicaid. So that was going to be a completely new aspect of our organization and how we were moving forward. And so we had to ensure that our finance office and finance team were structurally sound and was ready to be able to take this on. And they too were also had a good familiarity and understanding of the Unite Us system, and to be able to make some of those reconciliations to compare what was going on from our prepaid health plans. And so I think that would be the biggest thing that we had to do was, as an organization, build that infrastructure on our accounting side, because what we had done with Unite Us, which I know is different, Rochelle, than what your guys are doing, we had already had 7 years of experience with them. And so we had a little bit of a leg up.
Rochelle, can we pass it to you to add on additional things you all were thinking about?
Yeah, I think for us it was hold on, sorry, someone's knocking my door. I apologize. Can you don't
No
worry, I
worries.
apologize. They're not gonna go away. I apologize. Go on.
You're good. The trials and tribulations of living in small rural America. Lori, do you want to jump in? I saw you come off mute.
Sure. So in terms of, I'm sorry,
Sure. What are
Yeah.
the things outside of and beyond the technology element
Yeah.
that you
Mhm.
all needed to consider as you thought about stepping into saying, I'm going
Yeah.
to do this work in the waiver?
Yeah, I mean, so really when we built out Healy, it was really a matter of building out the infrastructure, social care infrastructure. And we thought about social care infrastructure. There's really two components of that. There's the data, the technology to be able to have a common intake and screening as well as a referral. And then there's also community health workers, the workforce on the ground to be able to ensure that there are people with a common approach to how we provide services to people and how we serve individuals to ensure that we are have that area. And so those have been the two pieces we've really focused on: the data to technology, the sharing of information and the referrals, and then really the approach of care for people in terms of having a community health worker approach and ensuring that we're carefully building trust with our Medicaid members and others in the community, and building trust with each other to do that work.
Thanks, Lori.
Mhm.
Rochelle, do you want to jump in?
Thanks for your patience.
Good.
What Lori was saying at the end, I would say I would echo a little bit. I think a lot of what we did to prepare was build relationships. Often in rural spaces, it's hard to get folks to be on board with new technology and another database and another space you have to enter information. And so it was being willing to go one-on-one with these leaders that I knew, right, in the nonprofit sector and the social service sector, and say, let me tell you a little bit about what's good about this, and let's trial it. Let's do it together. And so I ran some programs through United Way. I got some grants to get some dollars in another way that I said, the only way I'll take referrals is through Unite Us. And so it got folks invested in like, oh, this is working. I'm sending a referral. She's calling people. People's needs are being met. They're being cared for. And that makes me as a referral agency know people are getting the services that they need, right? And so I think that was a pretty good step for us in sort of building that trust, building that relationship, and showing sort of through our own actions that technology can really serve folks, but it also takes humans on the other end trusting one another. So that would be my little piece.
Awesome. And I'm going to build from that and just offer, first off, let me do a little bit of a repeat back because there's so much good knowledge there. First and foremost, the offering, Brandon, that you kicked us off with, which was like, I'm not changing who my organization is to do this work. You said we've been doing this work for 50 years. Lori said, I founded this network in 2017. Rochelle said, I'm a team of one and I've been in this community, right? I think that's a really important thing for folks to underscore is these innovation waivers are acknowledging the work you all have been doing for generations and decades and really leaning into and trusting the power of housing navigation all day. I've been doing that our entire careers. I think that's a super important readiness element to consider. The other thing I heard us offer was around the reimbursements and the finances and the operational revenue mechanics of a healthcare partnership requires us to think about our books in a way that maybe we haven't thought about it. And so really focusing on ensuring you're ready for that part of the partnership. An investment in workforce. At the end of the day, this is about serving people. And so I need to make sure I have the right bodies that are trained the right way, that we are honoring what these CHWs, promotoras, navigators, whatever they are, that I have them at volume and they're ready to go. The last thing you offered, Rochelle, which will springboard into our other conversation, is this notion of partnerships. Community health transformation requires, like, none of us are that great that we can do it by ourselves. Hopefully I'm not breaking the news to anybody. Hopefully that's not news for folks. And so really investing in the time and the space of what it takes to build a coalition of partners that are going to trust and be in the process with you and also be compliant, because doing things in coordination requires investment and oversight. And so I want to double click on that partnership side of the equation and get curious about what does good partnership look like. So Brandon, I'll start with you. I'm curious in that notion of thinking about partnerships and building out the Healthy Opportunities program. What partnerships did you find were crucial to your organization's successful engagement in that waiver? And what made them crucial and how'd you get them on board?
Yeah, thanks, Lauren. I think once again, I think North Carolina was a little more of a unique spot than some. We knew, and we had built our waiver based on the data we had already seen in the network for the 5, 6, 7 years before we launched. So we sort of built our payment model and our 4 social drivers of health that I mentioned because we knew that was some of the top most unresolved needs that we saw in the community. And what better way to incentivize our partners than to be able to get paid to provide those services of those unresolved needs? And so we were very strategic about that. I think anytime that you approach a partnership, Dr. Cohen, I mentioned her earlier, she made a comment early on in this. She said collaboration happens at the speed of trust. And so you must have trust in order to be able to have a strong collaborative and to have strong collaborative partners. And you build trust by first offering up what's important to that organization. What is the mission of Healy, right? What is important to Healy? What is your funding structure? What do you have to report on? And let's figure out how you being a part of this network, one, helps you be a solution to the issues that we're seeing in our local communities. And sometimes that's very customizable, depending on zip code to zip code to zip code. But then how can we help you, Lori and Healy, get to your next step or next mission, or pull together a grants report as a community to help you? So you always have to give more than you receive when building any type of partnership and collaborative. And the way that we do business through this platform and through the technology, and even now through the waiver, is built on change. We're changing the way that we typically do business. And that is changing the course of the Titanic. We're not on jet skis, right? And so that collaboration has to be intentional. It has to be strategic, and you have to give way more than you receive. And you have to find those ambassadors and those advocates that's willing to run with that flag, to be partners with you in order to get that whole shift to change, to get people on board. So, Dr. Cohen said it best. It's not mine, but collaboration really happens at that speed of trust. And so you got to find that trust first.
I really appreciate that, Brandon. And then the articulation of the work that is, right? Like that is effort y'all are putting in those streets and those partnerships and those communities. I want to kick it to you, Lori, to build on that theme. An emerging model, it's emphatic in the New York 1115 waiver, but it is an emerging model across other geographies, is this notion of a, let's say, trust broker, trust holder, all the things. Very often the generic word is a hub-like model where there is a single entity who's charged with building, I offer not just an adequate network of partners, but an equitable network of partners. And so as one of those network entities in the New York model, Lori, I'm wondering if you can reflect a little bit on for us on like, what are you excited about with that hub model? What do you think is going to work? And what are some of the things that you and your team are chewing on as you kind of take the mantle of that role formally?
Sure, thank you. And just kind of adding on to what Brandon's saying, it's definitely, stands up and falls down at the speed of trust, and for sure, but it's also in order to build that trust, in addition to offering more than you're receiving kind of thing, it's also about shared leadership, right? We all have to be having collective decision making together. So Healy's had a steering committee since day one that helped lead and of CBOs, of member agencies that are have helped to lead. And now we've transitioned to a governing body as required by the Social Care Network, which was nominated and voted upon by the membership. So they determine who the governing body is of Healy, and is really charged with ensuring network adequacy and network performance. So that is the role of the governing body, to have that collective decision making and that collective leadership. Yes, we're the lead, but we're just part of the network, and we have significant responsibilities as that lead, but we're only going to be as strong as the network is overall. So it's definitely about that trust building in terms of the social care network. And the positive of having that social care network is, in terms of that the lead entity taking on those responsibilities of contracting with vendors, contracting with the CBOs, contracting with managed care organizations, and being able to build a capacity building program for the CBOs, is that there's an entity doing that, right? And taking on all of that responsibility and all of that task in a shared leadership kind of way. So it's being, it's not just Health and Welfare Council leading Healy, it's Healy leading Healy and Health and Welfare Council executing on that. But it's also about, having an entity, a centralized hub entity, to be able to play that role allows the CBOs to then be able to focus on the provision of care for individuals, right? And focus on what is the value to my organization, and what am I contributing back to the network as well, and having that give and take. But the hub model definitely, and having that shared leadership ingrained in the hub model is really key, I think. And we've also gone kind of a step further. In addition to the governing body, we've set up a series of 5 committees to help continue to have a voice for every network member, all of our CBOs, as well as our healthcare and our managed care providers. We've actually invited our full ecosystem out to the table to be a part of those committees, to talk about what's metrics and sustainability, what's communications and outreach to our Medicaid members, what does it look like to have these new services and in combination with each other. So I think a lot of it is creating that space where people can provide the input so that there's a reason to want to be at the table with us.
I really appreciate that. Rochelle, I'm curious if there is in a very rural community version or addition to this partnership question. I saw you nodding along, but I'm very curious for your very rural perspective on this question in particular.
Yeah, I think partnerships that are crucial are at least for us, we're not only the major healthcare providers, but also some of the major nonprofit providers. And I would say those what made it crucial is not only to bring folks to the table to get their input, but I would say to help them dream. I think sometimes in a rural space, we see the needs, right? And yet we may not have the resources to meet them. And that can be hard day in and day out for for all of us. But I think to say, okay, so this is an issue, you see it's an issue. What if you had some funding to do it? Let's think about it. Let's get that imagination going. Let's understand some of these, because I think sometimes you in spaces where there's a lack of resources, your imagination can get smaller. And so I think that's the one thing that I would say that was crucial, is like bringing the right partners together for collaboration. So it's not a heavy lift on any one person, which is a big deal in a small space, but also this idea of like, let's dream big and let's actually like imagine if we could make it, if there's a solution, what would it look like? And so I think those were really important pieces.
I love that invitation and encouragement to not think in a space of scarcity, but to think in a place of abundance and collective effort. Nowhere is that more needed when we're asking folks to divulge things like, are you and your family hungry at home? Is the electricity on? Can you take your medications? And the underpinning of all of these programs is, like Emily kicked us off, health-related social needs. So I want to dip our toe into that a little bit, because I think partnerships to what end is to deal with that moment. Lori, I'll have you kick us off. Can you share a little bit what screening for health-related social needs is looking like for you and your program as it starts to roll out in January?
Sure. So, required of our waiver is to use the AHC screening tool to identify health-related social needs, which is embedded in UnitedUS, and being able to do those immediate referrals for individuals, but also to do kind of a deeper dive and look at eligibility assessment for enhanced nutrition and enhanced housing services, as well as enhanced care management on top of that to facilitate the nutrition and housing services. But all of that's embedded in UnitedUS, and being able to kind of move through the workflow and build out a care plan that will be in UnitedUS as well, to be able to identify needs. But again, it's really a big piece of it is really thinking about it as a community health worker would, in terms of putting the Medicaid member at the center of care, and what understanding what their needs are. If someone, as Lauren was just saying, has just shared their most intimate information about their lives, making sure that they feel safe and taken care of, to be able to do that as we're moving through the process of screening questions and eligibility assessments and referral. How do we ensure that we're continuing to wrap our arms around the person and providing the care that that person needs? So, yeah, we're incorporating screening tool, we're incorporating eligibility assessment, building out the care plans to be able to ensure provision of service for those folks, and some of these new services as well.
And I'll just alphabet soup. AHC is the Accountable Health Communities. I know you're living it every day, Lori, so don't worry. AHC is the Accountable Health Communities screening tool. The AHC was one of the early CMMI pilots focused on the intersection of healthcare and social services back in 2014. So that tool was created, and now, to Lori's point, it's being integrated into several waivers, either in all 11 or 13, depending on how you count them. Questions, or using those standard questions for select social needs, like Brandon was offering, and is the case in the scope of the North Carolina pilot. We're going to stay focused on program execution, and we're going to talk a little bit about that reimbursement conversation. Like Brandon mentioned earlier, that's a key element for the team to think about. To be ready, I got to act it like healthcare, and healthcare is tied to reimbursements and being ready for that. So I'll kick it back to you, Emily, to lead us through these discussions.
Awesome. Thanks, Lauren. Thanks, everyone. So getting into navigating HRS and reimbursement, I'm going to start out with Rochelle. But of course, typically community-based organizations historically really operate off of that grant funding model. And so as these waivers are gaining a lot of popularity, a lot of excitement across the country, right? But there is this transitional period where you're transitioning into these reimbursement models that might not be as common. So what has it been like navigating that process, and what advice would you offer to community-based organizations that are looking to leverage these Medicaid programs as a potential revenue source?
Yeah, so I think at least from my perspective in being in a rural space, it's understanding how they work, what's going to be needed to provide the service, and the timing of the reimbursement in and out, right? Like how much cushion does an organization have, and what kind of timing of a reimbursement do you need? And I think that's a really that is so dependent on the size of the organization, right? Some large organizations, they can wait months to get a reimbursement. Other small organizations struggle with that. And so I think streamlining and having really direct conversations about here's the timing. You know, we were in a space in the state of Missouri where their model was really helpful actually, in that they gave that money to the regional health centers. So the money's in the community, right? And so then that means the reimbursement is just from community-based organizations to health system and back, all in the same community. So that can happen quicker. That can happen in 2 weeks' time, right? Which makes people feel like, okay, we get our ducks in a row. We understand the folks that are meeting this service. And then we also understand the clarity of how to get reimbursed. And so I think it's setting up that structure to fit with the space that you're in and the organizations that are providing the service. So at least that was something that was really important for us.
Yep, totally. And Brandon, do you have an additional perspective to kind of offer? I know Rochelle was mentioning, of course, within Missouri's model, it's really flowing through the health systems, but with you and your partnerships with the prepaid health plans in North Carolina, anything to add to that on kind of this concept, not necessarily SLAs, but just partnership and knowing that when you can expect that money to come back through?
Yeah, and I do not want to jinx this right now, right? Because payments are coming fairly quick. Like Michelle said, we're able to get reimbursed, usually within 30 and 45 days of the invoice, which is really fast right now. So I don't want to, I'm knocking on wood. I hope that doesn't change. I think though, when you think about being community minded, it's also took a no wrong door approach with our prepaid health plans, right? So when in North Carolina, we have 5 prepaid health plans, and then we have our 4 LME MCOs who are now a part of this initiative as of this past fall. Typically speaking, our workflow process is we would get a referral from the prepaid health plan who has already determined eligibility of Medicaid and eligibility into the pilot, right? That's a good thing for community-based organizations because that takes the onus off of us. All we have to do is provide the service, right? Which is great. But I think being back to being community minded, a lot of our organizations provide lots of different activities, right? Whether it's housing, employment, or peer outreach or community health workers. And I think that what we learned about midway through was as we were starting and it was sort of slow, we were like, hey, how can we help these prepaid health plans? So we would actually identify people in the community that we thought, hey, you're not on Medicaid. You may be eligible. If you were going to be with a plan, who would you want to go to? Well, grandma's with Blue Cross Blue Shield. Okay. We would send a referral to Blue Cross Blue Shield through the network saying, hey guys, this us, we're part of the pilot, but this is somebody that may be eligible for Medicaid. This may be somebody eligible for the pilot. We don't determine that eligibility. We would send it to them and say, hey, they are food insecure or they are needing assistance with housing navigation. Screen them and tell us what you think. And then they would do their end of the work and then shoot a referral right back to us, which would have the payment model in there for the service in which we would provide. So I think that it has become a two-way street. It's not just us receiving referrals from the prepaid health plans. And also what's happened is we have prepaid health plans now that are sending us referrals for non-HOPS services, right? Which is just as important. We can't be just thinking, well, we're not going to serve anybody but anybody that's on Medicaid. Somebody who still may have a transportation issue that may not be a reimbursable expense. Well, our organization or another organization in the community may have programs set up to provide that service need. So we still have to keep our head on a swivel and be able to address all the needs of a community, even outside the waiver. And by doing that, you're bringing a tighter collaborative together that is actually increasing a healthier community. So the secondary, the tertiary, the ripple effects of the 1115 waiver is actually increasing more healthier communities, better healthier communities based on that kind of structure.
Totally agree. And I think just that ties back to that concept of true partnership and you redirecting those kind of new enrollees back to plans and just being able to, like, everyone has their role to play and it's really mutually beneficial to foster that true partnership. So thanks for touching on that. I also wanted to ask you, Brandon, obviously, you're the farthest along out of everyone on the panel. So you mentioned this in your previous response of kind of the uptick and post-launch really being able to scale the program. So how did you reach a point where you were receiving more of a steady stream of referrals? And how did that translate into meaningful or non-meaningful improvements in your cash flow?
Yeah, I think when we launched this, we only launched this in 3 different regions in North Carolina, and we had what they call network leads. So these were organizations usually spawned off from larger foundations that was going to be our technical assistance and keeping us within the left and right lateral limits of the program and helping to facilitate that relationship between a CBO, nonprofit organization, and a prepaid health plan. During that time, we had capacity building dollars. They understood that in order to be able to grow and to potentially get to scale, that they offered capacity building dollars, i.e. transportation. They may have given an organization $150,000 so they could buy 2 vehicles so they can provide transportation services to bill on the 1115 waiver. So we had those capacity building moments, and it was scattered. It wasn't a one-time, one-hit thing. NC Medicaid, working with their network leads, would offer this at different time periods, whether it be quarterly, biannually, when they found extra money in General Assembly. It was really a broadband shot at it. We realized at a certain level when referrals started coming in that we were able to take the money that we were making off of Medicaid reimbursements and start hiring more staff, hiring larger cooler systems and refrigeration systems or cooler trailers. We were able to start to do that on our own and didn't need capacity building dollars, right? And what we understood as an organization, back to what Lori and Rochelle talked about in the piggyback, it's about the community, right? And so we realized that, hey, we were fortunate enough to scale quicker, partly because we'd been on the technology longer. We were a larger nonprofit organization. Take that money, Impact Health, that our network lead, and give it to a smaller nonprofit that's also trying to grow, and we can help them grow. We don't need $100,000, right? Like give that to the community to grow, because we had gotten to a point where our income stream was allowing us to scale proportionately. And I think when you get to a certain level of that, you realize you have to start becoming innovative to provide those services. For us, feeding 200 families a week with hops and delivering food was easy. We're feeding 750 a week through the program now through hops and Medicaid reimbursements. Well, that's a whole nother animal, right? So the fact that we're now having to be creative and allowing DoorDash to deliver all of our healthy food boxes takes that onus of that transaction off our plate. But then we've got to hire community health workers to go on the back end to screen for those other SDOHs and to sit with that family and screen for other needs. And so every organization is going to look different. Some organizations are larger and have larger capacity. Some are smaller but want to get to that large capacity. So it's all about the health of the organization, all about the health of the community, right? And so I think you got to take both those into consideration.
I really appreciate that, Brandon. I'm just going to jump in to underscore 2 things that you said that are so poignant. Thing one is this transformation in our communities requires us to collaborate and not compete. And really holding on to that, oh, the head nods, it makes me feel better. Thank you, team. And you really holding on to that as this is a privileged opportunity for us to move towards a place where we can collaborate and not compete. And if that means uplifting the smaller provider who can do more instead of me hiring 5 more CHWs, be about that, right? And so I want to make sure to underscore that piece. And the other piece is, we're talking about 1115 waivers, all of the it's all so slice and diced, right? And it's such a small funnel, but people's lived experience is not just part of that funnel. And so really leaning into the innovation of braiding both revenue streams and service lines to do right by the family and the person and their family, using all of the tools in the toolbox, recognizing the Medicaid waiver is one of those tools, is I think really sage advice as folks decide, should I be in this and what shouldn't I do and how much is it going to change me or isn't it? So I just wanted to make sure to underscore those things. I know we have a ton of questions in the chat, Emily, and a final takeaway question too. So I'll pass it back to you to kick us off.
Yes, thank you so much, Lauren, Brandon, Rochelle, Lori. So we just quick time check. We got about 13 minutes. So we're going to do one rapid fire final takeaway question for you all. And then we are going to hopefully get to 1 to 2 of our audience Q&A. So final question, what was an unanticipated win that you and your organization had as you engaged in the program? So this is going to be rapid response. Brandon, let's start with you, and then we'll go Lori, Rochelle.
The ripple effect of the program. A short story, we saved a family farm that was going out of business because the program started buying food from this from this farm for our food boxes, which was a reimbursable. So instead of buying corporately or buying from a bigger food program, we started buying from local farms. And it wasn't just my organization, it was multiple organizations. And it saved a family farm in a small rural area. And if any of you know anything about small rural areas and family farms, watch a Hallmark movie, right? Like, seriously, that is the backbone of a community. And what we did was we decreased mental health or increased the improvement of mental health in that community, decreased the mental angst and depression of a family farm that had been there 150 years. So there is an economic impact to this program outside of our $85 a month per member that helps communities remain healthier.
Thank you so much, Brandon. Rochelle, I'm going to pass it over to you, and then Lori.
Thanks so much. So I feel like for myself, I knew a lot of the leadership at both the health systems and the nonprofits. However, an unexpected win for me was that they didn't know each other, as well as maybe I thought they might. And so I was realizing in all these meetings, right, for the Torch Grant, for Unite Us, for all of the waiver, all these meetings we're having, the unexpected win is people met. People are now meeting. Oh, I've heard about this. I've heard what you're doing. Tell me more. And that's a huge win. That's a huge, huge, huge win. So I think that was something that I wasn't necessarily thinking about, but really became clear. Was there a challenge part of it too, Emily? A win and a challenge, or no? Sorry.
We wanted to start with end with the positive.
Okay, good. I thought so. I was like, is there a second part to this question? I appreciate it. And it was great to be just a part of this conversation in general and feel like I've learned so much. And so I'm really grateful. Thanks.
Thanks, Rochelle. And Lori.
Yeah, I mean, when we first started Healy, we really asked folks, organizations, our network to leave their own mission at the door to create a bigger mission, which was really our social care network, our hub model. And fast forward, so that was in the fall of 2017. Fast forward this just last month, we convened our Healy network again, and we asked for folks, what do you think what's the benefit of doing this work with us together as part of the waiver? And it was, of course, serving people. That was always the first and foremost, but it was also, there was this bigger infrastructure change, this bigger systems change that people were going to be a part of. And there was a lot of emphasis and value placed on that. And so I think for me, the win is that has continued to stay a central piece of why CBOs are participating in Healy is, yes, to serve people, but also they want to be part of something that has long-term systemic change.
Thank you so much, Lori and Brandon. And I know Rochelle had to leave us early, but for offering those positive end notes of those unanticipated wins. Really appreciate the conversation today thus far, and we're going to open it up to some of our audience Q&As. So I'm going to start out with an operational question. How did you plan for the waiver operationally? For example, how did you model how many transactions one FTE can handle per billing period? So Brandon, I'm going to start with you on this one, just because you've been living it for a couple of years now. And then Lori, I know you're supporting your organizations with those capacity building funds too. So Brandon.
Easy question. We did not. So I tell you what, we have the luxury of doing, and I think it's built in. I can't speak for other states, but when we started and all of a sudden a waterfall hit, we had a lot of referrals coming in for the services that we said we were going to provide. We didn't have the capacity at that all of a sudden. It was like, oh crap, what do we do? What do we do? We don't want to not provide the quality of service. So inside the system and through our network lead and with our PHPs, we were actually able to turn off receiving any referrals until we cleared our queue and or built our capacity. Now, as we started this, that become aggravating to some of our prepaid health plans who were like, oh crap, you guys are doing really, really good. We want to send you more referrals, and now you cut us off. Now we've got to look somewhere else for these services. But it was okay because we were communicating, right? We were saying, hey guys, we're still here. We're in a pilot. Like, we've got to get our feet underneath this. All of a sudden, we went from 20 referrals a week to 300 referrals a week. We've got to build capacity, workflow processes. Can you guys help us with it? Unitas helped us with it. Our network leads helped us with us. It was a collaborative way to get us back up. Then we turned the referrals back on. So we actually turn on and off referrals for different domains at very different times. And to be honest with you, we still do that. Like, if we start a new service line and we've got 4 or 5 staff dedicated to it, and it's a new program and we're trying to figure it out, we may do it for 2 or 3 weeks and be like, oh crap, we got to call timeout. But we communicate that through our network leads to our PHPs. And so you control the volume in which you receive referrals, but it goes back to what we talked about. If it's all about making money, then you're not doing it for the right reasons. It has to be because you want to maintain a level and a standard that not just organizationally, but the community has set as the expectations of the program.
Thank you so much, Brandon. I think that's a really honest and refreshing response. I think a lot of times everyone's like, how is this magically all just going to come together and everything is going to operate like a well-oiled machine? And the reality is, back to that common theme, I think we're seeing a thread of partnership and communication. And really that is what's happening with and through these waivers. So Lori, over to you.
Sure. So I'll just add to that. And really, it is about having an honest conversation. We have about 700,000 Medicaid members to screen and refer to services, and about 240,000 that will be eligible for enhanced services. That's a lot of demand there, and a lot of work that needs to happen across our network of about 125 CBOs. So we are figuring out how we're doing that as we're building the workflows and rolling this out. As we start to roll out on January 1st, we are figuring that out. We've done a readiness assessment to determine how ready are our CBOs to participate in this and their interest and willingness to do it based on the fee schedules and what we have to offer to them. And then we'll be able to use capacity building dollars as we see network gaps in screening those 700,000 people and filling and providing those services for the other 240,000. We'll see the network gaps, and we'll be able to use those capacity building dollars to fill the gaps and ensure that we have network adequacy and a high level of performance.
Awesome. Thank you, Lori. And I'm just reading through. So there's one about using the reimbursements function. What are you seeing as your claims approval rate? I think I can touch on that one. Just an average across everyone who's using our claims functionality. Our average rejection rate is 1.56% compared to the industry average of about 16%, which is something we're really proud of. Brandon, anything that you want to add on to that?
No, I was going to say I was going to say 2%. So that's it's good to know you're right there at that. So, and for us, we are a little bit different in North Carolina, simply because we're not approving eligibility. Like the claims already, once we accept that referral for that service line, we've done it, right? So once we close that, we accept it, we close it out. That's what prompts the invoice and it prompts the payment. So we still have to close it out appropriately in order to get paid, but that's sort of the checks and balances that are in place. And that's sort of what our network leads responsibilities with the PHPs were with the state, is to ensure that, hey, are you actually providing these services? It's just as much up to the case manager or care coordinator or LCSW or clinician on the PHP side to talk to our team and talk to their clients to ensure that we're doing what we say we're doing.
Absolutely. Okay, I like this as a last question because we've obviously been focusing a lot on, now that these waivers are up and running or about to be running, how you're supporting them. But what are your recommendations for community care hubs? So, the network leads, SCNs, or community-based organizations in states without an 1115 waiver? How can you build this type of infrastructure from the bottom up instead of the top down? Any preference on who wants to go first? Okay. All right, Brandon.
Okay. I'm a bit biased in this because when we first launched the way that we were tracking SDOHs, take the payment functionality out of it. We were strictly a coordination center, a hub, where every community-based organization and provider sent referrals into the hub in order to get them to, support that service line. As we grew in scale, we went to a hybrid model. So we still have a hub, but now we have providers that can send referrals to providers for other SDOHs. That's how the payment functionality from the prepaid health plans down to our CBOs providing those services in the 1115 waiver. I think at the end of the day, the hub is a safety net. And so I think if you have a network lead or a hub model, it creates a safety net of both accountability and an insurance that somebody's not going to slip through the cracks of care, right? And so you have this, uncle or grandpa that's overlooking this, whether that be the state, whether that be a foundation, whether that be a small nonprofit organization who's a trusted entity in that locale, is that component. I think that's really important. I think that when you have a local organization be that type of hub, I think your ability to accelerate the speed in which this happens is better because they're more trusted, right? All of us trust our local organizations way more than we trust our capital, right? Or U.S. Congress. It's the local organization. So I think you can accelerate that. And I would take the smaller ones even into consideration and to help build that infrastructure for them to become that. Maybe that's their only role that they have, is to be that hub, right? So every community is going to look differently, but it always goes back to local grassroots efforts and how we do these programs and services, whether we're getting paid for them or not.
Absolutely. And Lori, would love to hear your perspective on this as well.
Sure. So I'm just kind of building on what Brandon's saying. It really is that a lead entity taking the reins of the hub to be able to, convene, build out, together, build out that collective leadership, the mission, the vision of something that's greater than any one organization. And since when you do that and you're able to consistently communicate out and consistently convene, then you're able to kind of build momentum over time, so that when that waiver does come, you're able and you're ready to really move into that space as a network. But a lot of it is just that grassroots coalition building of consistent communication, convening, and shared leadership.
Thank you so much, Lori. Thank you, Brandon. Thank you, Lauren. We do have 1 minute left, so I'm just going to close us out. I think we knew that today's conversation was going to be powerful and insightful, but just thank you all so much for the work that you're doing. Lori, good luck with marching towards launch day through the holidays, but we're going to be right there with you going through it. Just a couple of housekeeping items. We are going to follow up with the recording. I also know that there were so many great questions in the chat that we didn't get to, so we're going to be kind of following up as we can with responses to those answers that were asked. Appreciate everyone joining us today, and I think that's it. Lauren, anything else you'd like to add?
I would say it's not a moment, it's a movement. So leaning
we
in
go.
and using all these opportunities in front of you and reaching out for help when you need it, because we're in it together. But thanks for hosting the
Absolutely.
conversation, Emily.
Thank you all.
Have a good day, folks.